Is Dr. Shoaib around? Dr. Shoaib is around. If Dr. Shoaib.
No, I think he's busy with some of his commitments to patients, maybe.
So that's fine. And I could see Fatima, madam. And if Dr. Fatima, would you like to sort of give a brief summary of your master class so that we can go on to the question answer sessions?
Sure, sir. Good evening.
Good evening, ma'am.
One thing is I'm not able to switch on my video due to some reason. So is it fine if my audio is available?
We can hear you very clearly, madam. You can go ahead.
Okay, fine. Thank you. So first of all, thank you, Dr. Shamana, for introducing me, for making a part of this IPC Masterclass. It was a wonderful experience being a part of this IPC Masterclass. And as you know, I discussed about the outbreak management. And as we all know that outbreaks are sudden appearance of new cases or increase in the number of new cases. And talking specifically of the healthcare associated infections, the first thing is that we have to be vigilant at all times to notice any new trend or any change in the pattern of infections that routinely occur in the healthcare. So surveillance plays a very critical role in noticing any such trend. Once suspected, a proper stepwise approach is needed to properly investigate and manage the healthcare associated infections. And basically HICC has a big role while in training the staff for this outbreak management. But not only at HICC, entire team, it is basically a teamwork. So the entire hospital, the healthcare has to work as a team. And once we are a team, we can utilize our resources. And by going through this stepwise approach, do you want me to just revise the steps of this approach?
Ma'am, that's all right. We can, when we go to, since you have moderated a few sessions, please do give your brief summary on the sessions which you moderated, ma'am.
Yeah, so I have moderated Dr. Jaya's session, which was on evidence-based practices on standard precautions in IPC. And basically, what I think the objective basically of putting this topic on a masterclass platform, many times we think of, okay, it's just standard precautions, everybody knows it, there are some 10 or 13 parameters, what is there in it? But the importance, as Dr. Jaya has stressed, is how do you implement it? And what are the challenges? So whenever you are, as a healthcare professional, when you are entering into IPC as an infection prevention control professional, it is very challenging because of several factors, as Dr. Jaya had said. There are manpower issues, there are organizational issues, there are training issues. So how do we actually, as Dr. Nirav said, how do we prioritize, right? How do we prioritize what we need to follow, what can be followed in that particular setting? And how do we actually harness the support of the management? How do we harness the support of healthcare professionals? Because if you talk about antimicrobial stewardship, it's not just the IPC team. We have to actually talk to clinicians. We need to get the support of surgeons, which I think is a big challenge for everybody universally, right? So I think those are the things which we actually wanted to address, and we have addressed in these platforms. And as Dr. Nirav had said, when you talk about settings, even when we talk about surveillance in IPC, the first important thing is what are the things you need to, actually include in surveillance in your healthcare setting. Suppose you're working in a dialysis-based setup or you're working in an endoscopy-based setup. So you need to actually, customize, because one size doesn't fit all. So you need to customize as to what exactly should I follow in IPC. Is it feasible in my particular organization? Because we have a lot of international guidelines from CDC, from WHO, right? But please ensure that even we have a lot of audit tools. We say, okay, refer audit tool from WHO, from CDC, but at the level of primary or secondary, or even sometimes tertiary healthcare setups, we may not have those resources in our hands to actually implement those specific IPC protocols. And I think these classes have actually helped us in guiding us as to how do we stick to the guidelines and how do we customize it as to where we are working. And I think that is the essence of this entire, masterclass. And Dr. Fatima's presentation is again a unique presentation in terms of, because it talked about outbreak, and again, outbreak of healthcare associated infection. So I think, Professor, I think being an epidemiologist in public health, we normally talk about generally communicable, diseases and how do we manage. It's a very beautiful presentation by Dr. Fatima, very commendable. She had initially shared her slides and it's really very nice. The thing is that we had to, actually edit it so that we could look at how do we apply the same principles of investigation of an outbreak to healthcare associated infections. And she did a wonderful job. And in fact, right from evaluating hypothesis, there was some, I learned a lot during her presentation. So I think these sessions, the take home message from these sessions basically is, there are several things which are available on the net in terms of webinars, in terms of, knowledge sharing platforms, but how do we extract and how do we, basically use it to implement those IPC protocols in our setting. And the most important thing is, whenever we need to start implementing IPC protocols, the first thing is to look at what are the gaps which are actually existing presently in our organization, right? So unless we know where we stand, unless we measure where we are, we cannot really show an improvement anytime. So I think that is the essence of these classes. Anything else which anybody wants to pitch in, please do. I mean, I think I would really encourage a lot of questions, because that's how, people from different backgrounds actually learn about each other's best practices. Yeah, that's it.
Thank you very much, ma'am. Thank you very much. And since people are hesitating to put their questions and also, ask any particular questions, Nirav, some of the questions which emerged from your session was to do with, fogging in the operation theater, as well as in the RT-PCR labs, etc., as well as the use of UV. If you want to address those, and then related to which, if there are any questions, we will ask you, sir.
Sure. So the fogging is a kind of one of the favorite topic of almost all the, especially surgeons and all that. They wanted their OTs fogged up almost day and night. The reason is that initially there was no standardized protocol were available. Everyone was thinking just keep a formaldehyde overnight and the OT will be cleaned. I was used to tell all the surgeons, so this fogging is not, I used to tell surgeon, this fogging is not your brahmastra. You're going to not kill everything. You need deep cleaning is much more important than only fogging only. The reason behind it, fogging, normally we know, formally it is useful for only for airborne infection like TB. Then the organism is not going to be suspended in air for long. They are going to settle down in the OT surfaces like OT light, table and floor, all that. The deep cleaning or proper cleaning of these areas is much more important rather than fogging. Cleaning of air is not going to be useful unless the fogging is useful only in two cases, as airborne infection or plus to remove fungus for especially after any kind of major maintenance activity. Or you want to check your HEPA installation, your OT is new, HEPA installer new, AHU is new. To verify this efficiency or efficacy, OT fogging, so fogging is followed by this air culture. Apart from that, fogging utility is not very much useful. As for RT-PCR lab, again, we used to this old biosafety cabinet we are using. Then I don't see any rationale for any. Especially COVID virus is not that much airborne as other TB and all that. It is maybe aerosol generating procedure. It can produce aerosol, but not routinely. So when you are performing your process in biosafety cabinet, fogging not very much recommended. Unless so what happens normally when you emphasize more on fogging, the class 4 staff which actually doing the cleaning, they take this deep cleaning protocol for granted. They know what they are going to do for ultimately later on. So they are not doing the proper cleaning and proper deep cleaning disinfection part. So it is important for us to convey them that deep cleaning is the first any kind of modality of any procedure, followed by fogging as and when required, not for everything. That was the discussion. The second point was coming also like UV light. UV light is kind of elastic, especially like COVID. Like then many of the engineers of worldwide, they go fancy with this UV light. Everyone want to explore like everything like UV light. A disinfection shower was there to introduce initial part of the COVID. So they want to try out anything for the only kind of fear only. So UV light is there, but it's still new. I think the technology is extremely promising, but still, as we are discussing evidence-based precautions, evidence-based policies, we require still more evidence to its effective in actually real world. In vitro it is definitely effective, but in real world, in presence of organic matter, after proper cleaning is not proper, how it is much it is effective. It is still very early phase, but still technology promising. We need more evidence or more research on this field. Thanks.
Thank you very much, sir. I think related to which, I don't know if you want to take the question which has come up in the chat box.
Sure.
There's Dr. Samreen Khan, who's asked, sir, post renovation and construction in ophthalmology OPD, recommended environmental surveillance. I think, what is the recommended environmental surveillance? Apart from air surveillance for aspergillus, what else is recommended in terms of it? Thank you.
Okay, for surveillance of the reconstruction, normally what we recommend, just go for air culture plus surface culture. It's standard practice that just to know the efficacy of cleaning. Therefore, normally, as you know, surface culture is not that much of sensitive, especially when you are using disinfection solution and taking the surface culture immediately after that they are more or less coming out to be negative only. But the only ticket is kind of cultural work, cultural issue. When you're checking something, the person doing the cleaning will do it with a more efficiency. They want to be extra sure, and there should not be any growth in the culture. So the important is kind of ophthalmologic. We have seen cases after the proper renovation of the ophthalmic OT, fungal spore have been there. So apart from surveillance culture, what we need to look into is proper airflow in these ophthalmic OTs. We are seeing air remains stagnant in the OT. When you take the air culture, it comes to be positive. We need to ensure the proper workflow, proper airflow. The AHU is keep operational to keep the positive pressure, to maintain the positive pressure in the OT throughout the day. So the other measures we need to emphasize more upon.
Thank you very much, sir. We'll come back to you with another question which is there, but I'll ask Jaya Madam. Madam, you can take these three questions in, consequentially in terms of sequence. One is, with respect to prophylactic antibiotic prophylaxis as well as post-operative antibiotics. You want to address that initially. Then, very interestingly, hand hygiene on gloved hands, right? And the third very important thing is routine MRSA screening for all surgery patients. So if you can take, these in sequence, it will be, madam, please go ahead.
So starting with thank you, sir. Starting with the antimicrobial prophylaxis and for surgical prophylaxis, right, sir? So antimicrobial prophylaxis for the surgery, it's definitely it's required, and many we should have the proper antibiogram, local antibiogram. And accordingly, policy should be made. Policy antibiogram, to definitely it should be every time, according to the organizational policy, either 6 months or 1 year, at least 1 year, we should follow, and accordingly the antibiotic policy. So surgical prophylaxis, it's maybe in place in many hospitals, but it is very debatable that how much the surgeons are following. That is a very debatable. And the thing is, antibiotic policy always we prefer surgery wise. Like what kind of surgeries, what according to the site, and along with the type of surgeries, clean or clean contaminated. So definitely policies should be there, and it should be followed properly. And the timing, what we observed in our organization, that commonly the prophylaxis are followed. 80% cases are being followed, but the timing, the dosing timing, and the second is sometimes redosing is required. So sometimes, many times when redosing is not required, then also redosing happened. These things we need to follow strictly, and definitely nowadays it's mandatory to make the antibiotic policy for every hospitals, even the hospital like government hospitals or the smaller hospitals also. So definitely it should be followed. And prophylaxis, we have a guidelines also in the national guidelines also, but apart from that, we must follow our own antibiogram. That is the best one actually. And few things apart from that many clinicians doesn't have that awareness that when some antibiotic is going on, but it is not particular for that surgery, but still they are going because already the antibiotic is going on, so we are continuing. But the thing is different, that we are basically surgical prophylactic antibiotic we are giving for this to reduce this transient bacteria invasion, but the common GNB antibiotic which is going on, they continue. So these things awareness we are supposed to make aware everyone. And the second thing, I think, sir, you asked for the gloved hand hygiene. So initially we never told, that is, we always restrict the people to do the hand hygiene, the gloved hands. It's not at all recommended. In every book it is mentioned. But during this COVID pandemic, it's like due to the resources and all that restrictions, we have even WHO has recommended that global guidelines has given that a gloved hands hand hygiene can be possible. And many many articles, many studies has done over these things. So gloved hand hygiene in gloved hands. But definitely this period was pandemic and resources were becoming very restricted, limited resources we had to do. But now when we can consider it little lesser, like post-COVID era, not totally, but partially. So now we definitely will not recommend in the hand hygiene over the gloved hands. At least we have seen many cases, many surgical site infections, dressings in the gloved hands with the hand hygiene and all that. It's increasing. So definitely we will not recommend when the sources are at least moderately available. We will not advise for the hand hygiene over gloved hands. And any other one?
The third one was, MRSA screening for surgery patients.
Okay. MRSA for every surgery patients?
Yes.
So, sir, every surgery patients means it is earlier recommended, but I cannot say that the guidelines are not there or evidences are not there, but totally depends upon the hospital's policy. So some hospitals, the organization, they do like chlorhexidine in bath and all that as a not screening but prophylaxis. Many hospitals are routinely doing that the screening, that nasal and axillary. Few hospitals are only for the transplant patients, they are doing the screening. So depending upon but transplant patients, as it's a very high risk these things, so it is definitely preferable for this transplant. The other things are definitely depending, and moreover, like many patients, it's my personal experience, many of them are why unnecessarily the cost, the expensive cost. So routine surgical procedures all depends. So what you want, again prioritizing the things. As a transplant operations, transplants are very crucial. So definitely we should go for not only MRSA, CRE also.
Right. Thank you, ma'am. I think Fatima madam has supplemented saying that World Health Organization recommends MRSA for cardiac and orthopedic surgeries is what she has supplemented. Before I go over to her, Sukanya ma'am, please come in.
Yeah, just a small addition. I mean, it's whatever has been said is absolutely right. When we talk about evidence-based, right from our microbiology lab, we have a lot of evidence as to how many MRSA cultures are positive from a particular surgery. So if you feel that MRSAs are increasing in obstetrics, or if there are more of MRSA surgical site infections in different hospitals, we have implemented it for cardiac and orthopedics, especially your joint replacements, which are really difficult to treat if they're infected, because it's really expensive and it's very difficult to totally do a revised revision of TKR or THR. And in those cases, definitely, I think that as a microbiologist, in conjunction with the hospital administration and the quality team, we have to present the evidence as to why we have to include MRSA screening for such specific surgeries. Like, it's all based upon what Dr. Jaya and Dr. prioritize based on high risk and also based on which setting you're working in. So if you're working in tertiary care, which does around at least 100 to 150 joint surgeries per month, right? So it's a huge volume. And you have a lot of cardiac replacements with valves, and implant procedures, and that is from a surgical standpoint. And again, from microbiology lab, you're seeing a lot of MRSA cultures in specific, this cohort of patients. Then I think that it is definitely an evidence-based practice to put it into the hospital policy, which has got the evidence of background work, which is done by microbiology and the surgical feedback, surgeon's feedback. So that is something which is excellent, which is important. And coming to Dr. Nirav's question on fogging, as Dr. Nirav had rightly said, it's an often asked question, okay, but I would really, suggest to emphasize that one particular factor, in fact, surgical site infections are not, unifactorial, it's multifactorial. There is so much going on during a surgical procedure. So basically, I think that when we talk to anybody on fogging, it's important that all of us as IPC professionals actually say that it's a bundle. Like, how do we have bundle of care for prevention of healthcare associated infections? We have a bundle of interventions which need to work together in synergism, mutually advantageous to each other, and only then we can actually prevent a particular infection, whether it's surgical site or whether it's VAP or CORTI or CLAPSI. Yeah, that's what I would like to add. Thank you.
Thank you very much, ma'am. Before I go over to Fatima, ma'am, Pandya sir, I think there's one question which probably you may take it up. Is there any recommendation to do the routine water sampling from the OT hand scrubbing tub? Is a question which has come up. Both you and Jaya madam can actually, and Sukanya madam also can actually intervene. Go ahead, sir.
Okay, so basically, I think there are no written recommendation for any water sampling, for routine water sampling. What we can do is for targeted surveillance, like if you are surgical side or if for either OT or ICU, if any of the areas are growing more kind of infection through like Pseudomonas and also kind of bacteria, you're suspecting water is the source, then I think water sampling from OT is required. And again, if OT is, suppose once you have established OT water is kind of, ICU water is one of the source for this kind of an infection, then I normally recommend to just go for this frequent screening, so whether it is to prevent any other occurrence. So one is kind of corrective action, kind of preventive action. Corrective action, you just go for the culture, establish the sources of Pseudomonas. Like once in one of my hospital, during the COVID, there one Acinetobacter was coming out from a water source. So there was one issue, but that was not very common. Ultimately, found that the water was contaminated. They was not being cleaned since months due to COVID. So ultimately, it was one of the source was identified. So once it is established, even if there is one new case is identified after suppose 3 to 6 months. So, but even in that case, your priority area should be to look out the water. Whether this water is again contaminated or clear or not. So such kind of areas for targeted surveillance, water sampling can be done. We have seen many of cases. Because suppose ideal what was the recommended OT water should be clean. When they should RO water should be used for the cleaning, for the hand scrub. But what we were saying, there is a hot water during the winters. So normally RO water is mixed with the hot water. So that this water is not basically cleaned properly. It can give rise to Pseudomonas and all in the water. So that might contaminate the already scrubbed hands. So again, depend on your past experience in the hospital, your cleaning or maintenance program, and all the target and kind of specific type of infection coming out in the hospital acquired bacteria. So in that case, water sampling is required, but again, you need to prioritize all these kind of your resources. What kind of resources you are being given, and what are the areas you need to prioritize. Yes.
Thank you, sir. Jaya ma'am, you want to add anything?
No, sir. The same thing that routinely we can do for a few areas, prioritized areas where we need to do. Especially we do the like dialysis water, RO waters and all that. We can do routinely for the culture, and even we do like endotoxin also to be recommended. But the other areas where it is the normal areas or common areas, whenever it is required, we think that suspicion is there or some like we are in the culture, as Dr. Sukanya said, that we in microbiology department we can know that this area it's coming more or something, some particular organism is coming. Then that time we can, as a screening purpose, a surveillance purpose, we can do that area. But routinely a few things we do, the kitchen area or the water where it is like to be screened properly. the other areas. Moreover, we can do like the supply wherever the basic supply, main supply, or the where the filtration is happening and is coming down, kind of like tank and all that. Those water can be recommended the routinely, or depends if you are having this suspicion or if past experience. These areas we can do it, like culture and.
Thank you, ma'am. Thank you. So, Kanya, ma'am,
just that one is that I think that when we make this HIC manual and we talk about protocols, the one important thing which we can really do is to, as Dr. Nirav said, one is you do a high priority, high risk area, medium and low risk areas. So wherever high risk areas are concerned, like for example, your OT, dialysis, endoscopy, CSSD,
Yes.
right? These are some of the high risk areas which actually depend a lot upon the water quality in terms of IPC or infection prevention and control. And I think in those specific areas, it is good to have a protocol established in the manual as to what will be the frequency of cleaning and disinfection first. So after we finish that, we can say that once that is done, because the only method in which we can do a surveillance on environmental surveillance, as was asked in the question, is to do, to sample it. Now, the important thing is many of our microbiology labs are not equipped to actually handle RO water cultures, right? Because we need to not just look at coliform, we need to talk about endotoxin. And I think none of us actually working in hospital-based labs most of us may not have the facility to do in endotoxin testing. So wherever RO water is supplied in high risk areas, I think that is a good practice. Some of the best practices may not be recommended all the time, but some of the best practices are to do a little more frequent surveillance of RO water supply, especially when you're talking about dialysis, when you're talking about OT, and you're talking about CSSD. So again, the feasibility of RO water testing for endotoxin, it's a cost involved. So I think again, first we need to put a protocol of cleaning and disinfection frequency, and again look at first once in 3 months culture reports, or the RO water report which talks about endotoxin, and then if you feel that there are more the reports are more favorable, and the reports actually show growth of coliforms or show endotoxin presence, then I think depending on what the results are, we need to actually again look at what will again be the frequency of our RO water testing. So some of the tertiary care, sometimes the guidelines, they say every month, RO water endotoxin testing should be done. It's very difficult to get the management to, budget for that. It's very costly. But so I would say stick to certain protocols, but whatever you do, have a scientific background and have evidence-based background for it. Right. So why am I doing it once in a month? Because my RO water endotoxin reports have always been positive, so I am doing it. Right. Why am I sticking on to once in 3 months? It's not positive. It's never been positive. But I'm doing it once in 3 months because it's a high risk center. I can't, risk dialysis. I can't risk onco patients. I can't risk, OT or CSSD equipment which is supplied for sterile procedures. And other areas you really don't require to do it. So I again come back to the essence of the webinar, that everything should be evidence-based. Stick to the guidelines. Again, modify based on evidences from your own lab. Yeah, that's it.
Thank you, ma'am. Fatima, ma'am, there's a couple of questions which has emerged from what you presented. One of them is with respect to, this shift from hospital-based outbreak investigation to community-based outbreak investigations, and is there a sort of difference? And I particularly was also, looking at it when I did my session also in IPC 103, when a lot of our students did find it very difficult to look at an outbreak investigation in a community rather than looking at it from a hospital perspective. So if you can provide a little bit of an extension argument from the facility to the community, that would be great. And the second one with respect to reporting formats or reporting forms. So please throw light on that, ma'am. Fatima, ma'am.
Thank you, Dr. Shamana, once again. Actually, if we talk about the management of community-acquired outbreaks, then management is almost similar. We have to take the 10-step approach and all. The basic difference is we need to go out to the community. We need to teach them how to quarantine themselves, how to protect themselves from the suspected pathogen, and that is all. And the infection prevention practices they are supposed to follow as a community. Otherwise, the management is almost the same.
Right. And formats, ma'am, with respect to reporting forms and reporting formats, etc., is there all the same things which are used in IDSP, etc.?
The reporting forms also, as per my knowledge, is I think they are the same for the community acquired and for the HAI.
Right. Sukanya, ma'am, if you have anything to say on this?
Yeah, I agree with Dr. Fatima. The steps of investigation of an outbreak essentially remain the same. As when you talk about community outbreak investigation vis-a-vis the HCAI, it's only that you replace your streets or houses in community outbreaks to beds in an ICU or in a ward. So you can still do the mapping, you can still do the line listing. Only the criteria for line listing will be obviously slightly different when you talk about a healthcare associated infection. Based on what sort of healthcare associated infection it is, like suppose you take a VAP outbreak, or take outbreak due to MDR club causing VAP in your mechanically ventilated patients. Obviously, the clinical criteria for diagnosis of VAP will be different, and the risk factors is something which we always include when we talk about line listing of cases in healthcare associated infections, because those play a very important role for you to actually understand whether it's a true outbreak or whether it is only related to other morbidities which the patient could have. So most of the times in healthcare associated infections, if you look at it, I think Dr. Fatima had explained also, usually it is a transmitted sort of an infection or propagated sort of an outbreak which happen in healthcare associated infections. So I think we just need to, as we all understand, we need to look at how to manage a community outbreak investigation, and again bring it down to how will I put the same steps to tackle an investigation of a healthcare associated infection, whether it's an ICU. Many times these can be clusters and not outbreaks, again, as Dr. Fatima had explained. But I think that experience will come only when you actually do an outbreak investigation. For me, I learned a lot because when I first presented outbreak investigation, my personal experience, I was a novice. I presented it very, very sharp, very badly, in fact. And then I went back to community outbreak investigations, tried to put that and align it to healthcare associated infections, and then it became very good. And in fact, we were able to excellently point out what was the source. I would not say there'll be one source, there could be many sources as well as transmission pathways. Could be many when you talk about healthcare associated infections. Unlike when you talk about community, wherein usually you have a single source or usually you have one mode of transmission. Whereas in healthcare, you may have several different modes of transmission and several new sources getting added on, especially when we talk about COVID-19 outbreaks in ICUs.
Absolutely, so that's wonderful, ma'am. And I think one of the issues which people do face is the fact that they are structured as different steps, and we need to understand that some of the steps happen concurrently. It doesn't have to happen sequentially as one after the other, and that's something which we need to look at. And in the community-based outbreak investigation, a critical aspect is we have to look at the other social determinants of health, which doesn't apply as much as in a facility-based. Is something from my experience of working as a PHC medical officer and also an outbreak investigator. There's one question which it's addressed to all experts, and it says that please give your opinion on the use of shoe cover in high-risk area. Nirav ji, if you want to. Yeah.
Again, the shoe cover normally depends on the hospital policy. There are not as such high recommendation for that. If your hospital is properly following this cleaning and disinfection protocol, ICUs are getting cleaned every 4 hourly or 6 hourly. Actually, I'm working comfortable with the no issues with the shoe cover. Second is, I think they are asking everyone to wear the slippers. Sometimes it's interesting, their infection rate is not different. So the practically on infection rate, there is not a much difference on the whether you are wearing shoe cover or not. The only difference make it is kind of general hygiene rather than actual infection control. Suppose a patient relatives or any staff is coming from rural area or coming to travel through these local buses, all that. The only them shoe may get dirty, and they were bring all the dirt. It may be adverse affect the cleanliness of the hospital and the high risk area. But its really effect on any aspect about infection rate, it's really doubtful. It's really questionable. It is so it's more kind of hygiene issue other than a pure infection control issue.
Yeah, I agree with Dr. Nirav, because many times, actually, if you look at literature, there is no specific evidence which shows that you get healthcare associated infections due to dirt on the floor. But I think that basically it is a sort of a cleanliness issue, which is very important. And the greatest joke which I've seen is that, we tell all patients to wear shoe covers and remove the footwear and enter the ICU, but everybody else will be entering with chappal, with shoe, which is really I find it very, very funny, because how is it different? It's not that people are coming from some muddy village to your hospital. Like, if they're coming, then obviously you would also be traveling some amount or length of the time of that distance in the same scenario. But so I think that when we make policies about shoe covers, either it should be applicable to all or to none. And the basic thing is there is no evidence of shoe covers. This has been a bone of contention in many of the audits. But I feel that if we are following something, it should be 100% or don't follow it at all.
Thank you, ma'am. Dr. Fatima has also put a very nice practical solution in terms of the shoe covers and the, biomedical waste management. Please have a look at it. I'll take this last question before we hand it over to Mr. Lalit. I think it is to do with the biomedical waste management. And Dr. Vanita has asked, should we need to add disinfectant in sharps containers before closing the cap? If no, can I please get a reference for the same? So either of you can take it up, ma'am.
Yeah,
Dr. Jaya, please step.
Carry on. Is it, if it is, thank you, sir. If it is for the sharp containers, no need of adding disinfectant, because after this 2016 guidelines, it is mentioned as it is like just to put the cap, that is enough. It's not recommended for disinfectant need not to be added. So as per recommendations.
That's right.
Yes.
Any other additions, ma'am?
In the revised guidelines, it's actually given that we need not add it.
Need not add. This is mentioned.
Yeah.
Yes.
Since we have a couple of minutes more, I think I thank all of you. If there are any closing comments from either of you faculty to all the participants who have participated in this, please go ahead and make comments if at all there are. If there are none, I'll hand it over to Mr. Lalit, and you learn more than you share, and that is something which I always find by attending such master classes and webinars, and I think it's a continuous process. And thank you everyone for giving me this opportunity to be part of this session. Please go ahead, faculty, if you have anything to add.
Thank you, Dr. Shamana, for a wonderful session. As usual, always expected of you, always excel every time. So that's something which I would really like to put in. And excellent session. I think we had all faculty being very interactive and participating very well. So thank you all once again.
Thank you.
Thank you so much.
Thank you. Nirav ji, if there's anything?
Yeah, thanks a lot for this wonderful discussion that we are.
Thank you. There are a few more things which I think probably we will have, concerned individuals, faculty can be asked, but I'll hand it over to Mr. Lalit. Thank you very much.
Yeah, I think yes, it was once again wonderful, for having attendance from not only India but from also other countries, and all of us coming together on the IPC issues and addressing the current burning issues and taking them on board. And this of course gives us a very clear idea on how to go about and making things better when it comes to infection prevention and control, because this is not just a single day thing or not just a one day thing. It's a continuous process which has to be observed across all healthcare settings and also at our personal levels wherever possible. So we really hope we'll come back in a very short span of time for the next season of IPC Masterclass. So IPC Masterclass 6.0 will very soon come across the dates. We'll announce the dates because from this IPC session we have really learned on a few issues which needs urgent addressing. Like one of which is the biomedical waste. We have seen. Some good number of questions flowing in during the sessions for biomedical waste management and then other such issues. So definitely we are going to address all of them, and we are also going to take up with the specialty practices for we had a segmented area for this time across the IPC in dialysis centers. So like that we are going to slowly get into the specialty zones of the current IPC practices in a specialty area of like a dialysis or IVF or in a gynec or maternity settings, or like as we discussed today in the orthopedic settings, what are the recommendations and how it is. So we'll try to sharpen our objective more in the next sessions, and definitely we again look forward to each one of you being a participant in all those sessions, and we keep exchanging the knowledge. Any questions or queries which could not be taken up due to paucity of time can always be sent across through a mail at mgr.marketing@sanmed.in. So all your questions can be sent across to this mail ID, and we'll set it across to the speakers who are always there with us on board, and we will get the queries clarified and come back to you in a very short span of time. So thank you everyone. Thank you once again for your active participation, and it was a pleasure having you all on board. Thank you speakers and moderators and all attendees. Thank you Professor Shamanna for taking this session of the panel discussion so wonderfully, and we look forward to meet all of you very soon. Thank you.
Thank you, sir. Thank you. Have a great day. Thank you.
Thank you, sir. Thank you very much.
Thank you. Thank you so much.
సమ్మి ఒకసారి ఇట్రా. రేపేం ఎగ్జామ్ సమ్మి? ఏం చేస్తున్నావు సమ్మి నువ్వు? సమ్మి మార్కులు వచ్చిన తర్వాత మాత్రం మామూలు నేను నమ్మను నువ్వు చేస్తున్నావంటే.
students అంటే 40 students కదా. మమ్మీ ఇక్కడ ఈ గ్రాఫ్ ఇచ్చారు, x యాక్సిస్